Welcome to this medical education program, which focuses on stomach motility, dysmotility, and its clinical implications. To explore the program, you are invited to press the left-hand side buttons, which allow you to choose the subjects of interest to you. Your first choice, the highest menu, is between normal motility and dysmotility pathology. The bottom buttons have a more general function. If the information on a subject takes more than one screen, you can press the Continue button, which brings you to the next screen. This button will light up until the last information is given. This button will give you a repeat of the last information you heard. The Info button gives a short introduction of what is behind the left-hand side buttons. If you want to go back to higher level menus, press here. This button will show you how the program is structured and where you are now. Finally, if you are watching a text screen including one or more reduced size images, graphs or drawings, you can zoom in on these by clicking on the image. The cardia is the proximal part of the fundus. It is the transition zone between esophagus and fundus. Histologically, it contains no parietal or chief cells. Functionally, it is entirely integrated with a lower esophageal sphincter. This lower esophageal sphincter is in fact a high-pressure zone, which can only be detected with manometry. The fundus is a storage room. It takes no part in the active grinding-mixing contractions. This is nicely demonstrated in this global phase image of the stomach. It shows the different levels of mechanical activity in the stomach on a colour scale. The fundus, which is totally black, is mainly a tonic muscle without phasic contractions. In the antrum, two phasic contractions are visualized. So in fact, functionally, we have two stomachs. One for storage, the fundus, and one for grinding, the corpus antrum. The storage of food in the fundus is an active motile process. Indeed, the tonic pressure in the fundus changes as food is about to enter it. A distinction is made between receptive and adaptive relaxation of the fundus. Receptive relaxation occurs in the proximal part of the stomach. It is induced upon swallowing. So in fact, the fundus is ready to receive food by reducing the tone of lower esophageal sphincter and cardia before the food gets there. Receptive relaxation will be maximal for every bolus of food entering it. Adaptive relaxation is a different phenomenon. Here, the distal part of the fundus is concerned. The relaxation of the muscle starts only as food enters the stomach. Finally, the relaxation is not necessarily maximal, as it depends on the amount of food ingested. Have a look at this scintigraphic picture of the human stomach, in which food is actively processed. Not all the food is in the contracting antrum. Some of it remains stored in the fundus. In fact, food is only gradually released to the distal stomach. This is nicely illustrated in the following dog experiment. The radioactively labelled meal ingested by this dog was followed scintigraphically. In fact, the amounts of radioactivity appearing in the total stomach, in the antrum and in the intestine were measured in function of time. When plotted in a graph, it appears that the stomach is rapidly filled. The food, however, is not immediately transferred to the antrum to be mechanically processed. In fact, it is only gradually released to the antrum to a certain plateau. This plateau volume of food is probably the maximum which can be handled by the antrum for optimal grinding and mixing. Only after grinding and digestion in the antrum has been going on for some time does the stomach start to gradually empty and the intestine to fill up. The time which is needed for the stomach to start emptying its first digested food particles into the intestine is called the lag phase. So, in fact, the fundus will retain all excess food which cannot optimally be processed by the antrum. As the antrum starts to empty, the stored food will gradually be released into the gastric mill. Blue colouring of the connection between fundus and corpus is an indication that radio-labelled food particles are exchanged between both compartments. Liquids will also initially be stored in the fundus and be retained there by the mid-gastric band against the Newtonian laws of gravity. Fluid will pass directly through the antrum, without inducing the strong mixing grinding contractions, into the duodenum, only aided by some shallow peristaltic waves. This difference between solid and liquid emptying is characterized by the absence of a lag phase in the latter case. The mid-gastric band was first described in the journal Gastroenterology in 1986. Amongst others, this stomach of a condemned prisoner who was executed in 1919 was shown. As is the custom, a last meal was served, which you can see stored in the fundus in this drawing of the prisoner's stomach. What's also striking is the deep contraction which divides the stomach into two parts. Why this band is generated should be further investigated. The mid-gastric band is not anatomically identifiable. When food is ingested, it'll appear as a contraction, separating the fundus from the corpus and dividing the stomach into two parts, a storage part and a milling part. This distribution of the job among two different anatomical parts of the stomach is probably what evolution's found to be the best way of processing and digesting our daily diet. In cows, for instance, 4 functionally and anatomically distinct entities seem to be needed to cope with their diet. Like the heart, the stomach contains a pacemaker. The interstitial cells of Cajal are believed to play an important part in gastric pacemaking. All smooth muscle cells in the stomach show spontaneous activity. Those in the upper part of the fundus have the highest frequency of contraction and will therefore dictate their pace to the rest of the stomach. Because of this spontaneous contractile activity, the stomach, like the heart, will continue to contract even when all external innervation is sectioned. In the stomach, the tight interconnection of the smooth muscle cells itself is responsible for gradually transmitting the contraction wave from corpus to antrum. Contractions are initiated at the border between fundus and corpus, where the pacemaker zone is located. In this picture, which transposes the dynamic contraction into colours, the exact spot from where the upper contractions start is clearly visualized. The lower contraction, which was initiated 20 seconds earlier, has reached the antrum. This can also be shown dynamically in these images from a contracting dog stomach. Extensive secretion of acid and enzymes is not sufficient to get rapid breakdown of the food. Of equal importance is a thorough mixing and kneading of the bolus of food to get it optimally saturated with the digestive juices. In addition to that, the grinding will see to it that large particles are mechanically broken down into smaller parts. This process of grinding and mixing is achieved by propelling the bolus of food every 20 seconds into the narrow antral funnel, which heavily contracts and then sends the bulk back to the main body of the stomach. Continuous recording for 2 hours of the contractile behavior of the stomach during fasting shows this pattern. The migrating motor complex pattern is very characteristic. After a quiescent stage, also called phase 1 activity, the stomach starts to contract irregularly, so-called phase 2 activity. Then the irregular motion gradually changes into a phase of clear, rhythmic contractions, phase 3 activity. Soon this wave of motion shows a steady rhythm of 3 contractions per minute, after which it quickly returns to a quiescent stage. The fasting stomach cycle of rhythmic motion is transmitted to the duodenum, where the contractions increase to a rate of up to 12 waves per minute. There is no anteroduodenal coordination here. With some delay, this contraction front will also reach the lower small intestine. There the frequency drops from 12 to about 10 over the length of the intestine. The function of the migrating motor complex is believed to be that of a housekeeper. All indigestible solid particles which are too big to pass the pylorus during the normal postprandial contractions will be cleared from the stomach and moved down the GI tract. In healthy subjects, MMCs run during one's whole life and are only interrupted when solid, not liquids, are ingested. Deficiencies in the migrating motor complex will lead to bezoar formation in the stomach and to bacterial overgrowth. At a dose of 16 nanograms of pentagastrin, only very small and irregular antral contractions can be observed. This means that the acetylcholine, which is released from the nerve endings and which increases electrical activity in the smooth muscle cells, will only lead to irregular contractions in the antrum. At 64 nanograms, the antral contractions are regular and clearly stronger. Electrical activity in the corpus and its pacemaker zone is still not sufficient to induce smooth muscle contractions. At 256 nanograms, the corpus also starts to contract. Maximal activity, however, is not yet achieved. To see deep contraction waves initiated in the corpus and rolling over the antrum, up to 2048 nanograms need to be injected. At 2048 nanogram, maximal activity is induced. Strong, ring-shaped contractions starting in the corpus and rolling distally towards the pylorus can be observed. Note that a wave starts at the proximal corpus, while the preceding one is still progressing over the antrum. This fact that more than one wave is active simultaneously in the stomach is explained if you press Continue. Contractions are initiated at the border between fundus and corpus, where the pacemaker zone is located. In this picture, which transposes the dynamic contraction into colours, the exact spot from where the upper contractions start is clearly visualized. The lower contraction, which was initiated 20 seconds earlier, has reached the antrum. Another observation here is that the waves progress in all strength up to the pylorus. However, there is no progression of this wave into a duodenal contraction. This is typical for pentagastrin, which acts only at the level of the stomach. In real food-induced contractile stomach behavior, the coordinated prolongation of the wave into a duodenal contraction is of paramount importance for physiological gastric emptying. Strength and velocity of the waves can be measured with a force transducer. Pentagastrin is the active form of gastrin which is secreted in the stomach. Pentagastrin induces acid secretion by the parietal cells. When the pH is sufficiently low, A negative feedback mechanism reduces pentagastric secretion. Pentagastrin also stimulates antral motility, and therefore the mixing and grinding processes in the stomach. Therefore, the main function of pentagastrin is to improve digestion. Pentagastrin also induces excessive relaxation of the fundus, so that there's a tendency for the ingested food to remain there. Also, there's no effect of pentagastrin on antroduodenal coordination. Gastric emptying will therefore be delayed. These experiments with a guinea pig stomach nicely show the difference between a stomach with poor antroduodenal coordination and one where antral waves are nicely propagated into the duodenum. This is a preparation with irregular antroduodenal coordination. Only occasionally does an antral wave pass the pylorus. Cisapride is a drug which can improve antroduodenal coordination. It is administered here. Cisapride markedly increases the number of antral waves that pass the pylorus. This animated sequence shows what should occur with normally processed small digested particles which enter the duodenum. An efficient contraction wave, which is the propagation of the gastric contraction, will propel the particles further down in the intestine. This will function optimally if the same wave which has exerted pressure to press small food particles into the antrum is the one which will pass over and close the pylorus and propel the duodenal food. Let's also mention that the pylorus starts to contract ahead of the antral wave, that is, about 3 seconds before the contraction reaches and closes it completely. This pyloric precontraction will increase the grinding effect of the antral wave. Contractile force and frequency can be measured with strain gauges. A force transducer consists of 2 strain gauges functioning as 2 legs of a bridge of wheatstone. Contractions disturb the equilibrium of the bridge, which results in a voltage difference. In that way, contractile force is measured and the frequency is registered. The force transducer is fixed with a deep stitch to the serosal side of the gastric wall in a transversal direction. Propagation velocity of the contractile wave can be qualified by applying 7 force transducers in line. Recordings are made on paper and on magnetic tape. This is a recording of gastric motility with 7 force transducers. This is an endoscopic view of stomach contractions. They are induced by bringing air into the stomach. Although this is not a physiological situation, it shows how strong the antral contraction can be. The antral walls do touch each other. With food in it, it's quite clear that a strong grinding action can be obtained. The grinding action of the antrum is illustrated in this animation. Different sized food particles are propelled towards the pylorus. The pylorus contracts ahead of the wave so as to allow only very small particles of 1 millimeter or less to pass into the duodenum. All larger particles are propelled back into the antrum after having been grinded by the deep antral contraction. These repeated grinding and mixing actions by the antrum can be very clearly seen in the scintigraphic recordings. The sequence of processing food in fundus and antrum is well orchestrated. This is nicely illustrated in the following dog experiment. The radioactively labelled meal ingested by this dog was followed scintigraphically. In fact, The amounts of radioactivity appearing in the total stomach, in the antrum and in the intestine were measured in function of time. When plotted in a graph, it appears that the stomach is rapidly filled. The food, however, is not immediately transferred to the antrum to be mechanically processed. In fact, it is only gradually released to the antrum to a certain plateau. This plateau volume of food is probably the maximum which can be handled by the antrum for optimal grinding and mixing. Only after grinding and digestion in the antrum has been This is the stomach of a patient with poor antroduodenal coordination. Contractions seldom give rise to expulsion of barium through the pylorus. In other words, contractions tend to be inefficient. Even though antral contractions do occur and the duodenal bulb is being filled, it empties very rarely. In this patient, 10 milligrams of cisapride was administered, which produced an immediate increase of gastric and small intestinal contractility. Antral contractions arose with extremely high, almost occluding amplitude. The duodenal bulb was filled and emptied rapidly. Gastric tone recording of a malfunctioning stomach shows how these contractions with low amplitude are only very irregularly followed by a duodenal wave, the little blue bars on the bottom. If a drug like cisapride, the red arrow, which stimulates acetylcholine release from the myenteric plexus, is added, the amplitude of the contractions increases, but also the gastric contraction waves are now consistently followed by a duodenal wave. It illustrates that antroduodenal coordination is very dependent on a well-functioning myenteric plexus, and that cisapride can restore it. If atropine is added, the blue arrow, to block acetylcholine release from the myenteric plexus, contractile activity is lost. At this stage, the contraction wave has already started in the pacemaker zone, but is not clearly visible here. The reason is that it runs quite slowly in the beginning, and that although the pressure increases locally, the large bolus of food in the corpus is not visibly squeezed yet. The fundus contains food which does not participate in the grinding mixing process yet. Some secretion of gastric acid and digestive enzymes takes place. The stored food will only gradually be released into the gastric mill. Blue color. Here, the contraction wave progresses with increasing strength and speed. The contraction is clearly visible and tends to split the food up in two parts. Large particles are trapped ahead of the wave and pushed distally. The kneading action on the bolus of food which is obtained through this movement will improve mixing of the food with the extensively secreted gastric juices. This will fasten the chemical and enzymatic digestion. Here, the pressure becomes so high that the contraction wave has a truly grinding action on the large food particles. They are pressed through a narrow antral funnel and will bump against a nearly closed pylorus. The bulk of food particles is still too large to pass the pylorus and will be propelled back into the antrum. Some small particles are pressed through the pylorus. This is the stage where the antral wave will go over the pylorus and be taken up into a duodenal wave, which will take the digested food further down. This clearance of the duodenum is important to make place for new food. If this didn't happen, food would accumulate and obstruct the passage. Therefore, normal antroduodenal coordination is of paramount importance for normal gastric emptying. It's actually believed that before the contraction wave gets there, the pylorus elevates its tone some 3 seconds in advance. This obviously will even reinforce the grinding effect. This maximal contraction and closure of the pylorus lasts until the gastric waves reach it. In patients with typical stomach dysmotility symptoms, gastric emptying can be too slow or too fast. There are some differences between patients consulting a specialist and patients visiting a GP. But in most of the cases, slow gastric emptying is the most common underlying disorder. A problem for the correct diagnosis of slow or accelerated gastric emptying is that the symptoms overlap. Some additional symptoms, however, are more specific. In about 50% of the patients who have dyspeptic complaints in the absence of an organic cause, slow gastric emptying can be observed. This is often due to antral hypermotility or even atony, which affects liquid emptying less dramatically. Therefore, liquid emptying curves in dyspeptics and normals do not differ much. Diabetic gastroparesis is the result of associated neuropathy. After meals, diabetics suffer from hypermotility of both the proximal stomach, or the fundus, and the distal stomach, or the antrum, whereas tonic or phasic contractions of the pylorus are often too strong. This results in delayed gastric emptying of both solids and liquids. Slow emptying of large food particles may be the result of the absence of phase 3 contractions of the migrating motor complex during fasting. Finally, disturbed gastric emptying will also disturb food or glucose uptake in the bloodstream. Treatment of the motility disturbance contributes to a more stable blood glucose control. In patients with a gastric ulcer, solid food emptying is often delayed due to antral hypermotility. In patients with duodenal ulcers, emptying of solid and semi-solid food is often accelerated, as if the stomach fails to differentiate between solid and liquid food. After healing of the ulcer, gastric motility remains disturbed in some of the patients. Anorexia nervosa is considered to be a psychic disorder. In addition to reluctance to eat, weight loss, and amenorrhea, patients very often complain of fullness, bloating, and early satiety. In some patients, the latter complaints are associated with delayed gastric emptying. With electrogastrography, stomach dysrhythmias could be demonstrated. Whether the psychic disorder has led to secondary gastric dysmotility, or whether primary dysmotility and associated symptoms have generated a resistance to food intake precipitating the psychic disease, is at this moment an unresolved question. An investigation will often be performed to exclude underlying organic causes, of which the most frequent ones are listed. In most of the patients, no organic cause will be found. If no underlying cause is found, one speaks of idiopathic, functional, non-ulcer or non-organic dyspepsia. In recent literature, the term functional dyspepsia is the preferred term. The most prominent symptom in functional dyspepsia is abdominal discomfort or pain. Based on the additional symptomatology, one can differentiate between dysmotility-like dyspepsia, reflux-like dyspepsia, and ulcer-like dyspepsia. In a recent review on dyspepsia, Dr. Neil Jones from the United Kingdom reviewed the available epidemiological studies which show that the prevalence of dyspepsia in the whole population is on average 32%. In the same publication, Dr. Richter focused on those dyspeptic patients whose symptoms were judged severe enough to perform an endoscopy. After reviewing 14 studies, including 14,000 patients, it appeared that in 46% of the cases, no organic lesion was found. In 4 studies, including 3,667 dyspeptic patients, which had been referred to a gastroenterologist, endoscopies were performed to detect organic lesions. These figures were recorded. It was also observed that cancer as a cause increases with age, while on the other hand, reflux esophagitis decreases with age. According to Professor Malagalada, the putative motor disturbances in functional dyspepsia which may lead to delayed gastric emptying, reflux esophagitis, or increased enterogastric bile reflux are the following. The frequency of delayed gastric emptying in functional dyspepsia varies from 30 to 80%, depending on the literature source. Antral dysmotility generally correlates well with delayed gastric emptying. The correlation varies from 25 to 70% in dyspeptic patients, depending on the study. In a recently presented abstract, the results obtained after refined manometric measurements in dyspeptic patients were reported. Not only frequency and amplitude, but also the direction of the gastric contraction waves was assessed. Dyspeptics clearly have more retrograde waves. Isolated pyloric pressure waves, which slow down gastric emptying, were also more frequent in dyspeptics. The results are presented in this graph. It became clear that in the investigated group of 11 dyspeptic patients, all had at least one motility disturbance. The possibility of an acid-related etiology in functional dyspepsia has been extensively studied by Dr. Naren. His review of all available data made him conclude that gastric acid plays a minor, if any, role in the pathogenesis of functional dyspepsia. The impact of these findings on treatment was discussed. The meagre evidence in favour of a role of acid as a cause of dyspepsia is based on the response to H2 blockers in some studies. However, the formidable problems associated with designing such studies and the possible pitfalls that exist make the significance of these data uncertain. Indeed, one major pitfall is certainly that H2 blocker-treated dyspeptics which respond favourably, when referred for endoscopy to evaluate whether there was an underlying cause, may end up on a waiting list, and an ulcer which may have been present can have healed meanwhile. Such patients, contrary to what is often believed, gastric secretory capacity is not any greater in patients with a variety of upper GI diseases, except for duodenal ulcer. In the study by Campbell, referred to earlier, a strong correlation was found between a low acid output in dyspeptic patients and severe motility disturbances. This observation is not new, and it is also in line with what Bonnevie reported, that dyspeptic patients with the lowest acid secretion have the most severe symptoms. Dr. Richter reported a study from Talley and co-workers where the personality profiles of dyspeptic patients were compared to those of asymptomatic patients or of patients with other diseases. Professor Teitgat studied this matter in depth based on actually available data. The presence of H. pylori clearly increases with age in asymptomatic control patients. Various meals are used. Caloric value is about 500 cal. Very often, in practice, scrambled eggs are used to which the radioactive tracer is added. Here, labelled white of an egg is added to an hamburger. If several successive scintigraphic recordings are taken at short time intervals, 3 per second, and then put one after the other with the help of the computer, a dynamic image can be obtained of the gastric contractile pattern, while at the same time the fate of the labelled food can be followed. If you press on the stomach, you will make it move. The movement is accelerated 5 times. This moving stomach nicely shows how the stomach, while processing solid food, is divided into 2 functional parts. This moving stomach Although the flexible endoscope is widely used in daily practice, endoscopy is not the right technique to monitor GI motility disturbances as it influences stomach motility in a non-physiological fashion. For educational purposes, however, if you press continue, you will see through an endoscope how a contraction generated in a stomach inflated with air rolls over corpus and antrum up to really closing the latter before it reaches the pylorus. In terms of clinical studies, up to January 1991, 51 double-blind and 31 open studies, including 4,441 patients, had been performed to investigate cisapride in indications where dysmotility of the stomach plays a major role, such as dyspepsia and gastroparesis. The efficacy of cisapride in gastroparesis of different types has been confirmed in a large number of studies. This is a list of conditions which were investigated. Idiopathic gastroparesis and dyspepsia are by far the most frequent gastric motility diseases of this list. Let's therefore concentrate on these indications. It's not possible to review all the studies, therefore 5 of them with typical results were picked out. The gastric emptying half-times of both solid and liquid meals were normalized after 6 weeks of cisapride therapy, which was not the case in the placebo group. Dyspeptic symptoms improved significantly with cisapride. The symptoms associated with gastroparesis cannot be differentiated from those in idiopathic dyspepsia, except that in some cases they may be more severe. After 4 weeks of treatment with cisapride, the symptoms improved considerably.